This is an individual patient case study on colonic acute diverticulitis by Lauren Lindeman, a dietetic intern and master's candidate from the University of Texas Medical Branch in Galveston. This was presented at the Houston Methodist San Jacinto Hospital in Baytown. An overview of the topics that we are going to cover includes risk factors, pathophysiology, Hinchley classification, Ambrosetti classification, medical management, complications, surgery, MNT or medical nutrition therapy, the patient history, including social, food and nutrition, and medical history, the physical assessment, the results of the CT scan of the abdomen and pelvis, the medical diagnosis, significant lab values, surgical intervention outcome, nutrition assessment, diagnosis, prescription, and intervention, goals, monitoring and evaluation, results, nutrition education, the summary and conclusion, and references. Risk factors for the development of diverticulitis include the Western culture. Our diet as a whole puts us at a greater risk. However, we also have an increasing aging population, so researchers have debated whether it's our Western culture or whether it's our aging population that makes it so common for diverticulitis to be in Western culture. That also goes for the UK, Switzerland, many other countries in Europe that are similar to the US and in socioeconomic ways and in development ways. Also, having previous cases of acute diverticulitis puts you at greater risk for having a reoccurring incident. About half of the patients have one within 1 year of having a previous incident. Being obese or BMI over 30 also puts you at a greater risk. This is another association with the Western culture, and so researchers have debated for a long time if it's actually our culture or the obesity that causes it, or if it's just an association. Smoking, lack of physical activity, low fiber and high red meat consumption, genetics and specific genetic mutations put you at a higher risk for the development of the disease, colonic microbiota and motility, and also age-associated neurological dysfunction that may cause any kind of dysfunction in motility in the colon, and use of aspirin or NSAID medications. The pathophysiology through metabolism and functions of the colon include just changes in the neuromuscular functions. The circular muscle is thicker, so the one that wraps around the colon becomes thicker than usual, and the longitudinal muscle that contracts and pushes anything out of the colon becomes shorter. So this causes a decreased colonic transit time as well as increased pressure in the lumen, and polyps appear as you see in the picture, and these polyps can be very painful. Any obstruction of fecal matter in these polyps can cause inflammation and abrasion of the mucosa, so the lining of the colon becomes really inflamed, and any kind of perforation of those diverticulum or polyps can also lead to more inflammation. These changes, the neuromuscular changes, are associated with a neuronal or neurological decline with age, and it's also associated with reoccurring incidences. researchers have debated whether the aging is independently causative of this change or whether the reoccurring incidences causes the lining or the lumen to become more sensitive to these polyps. But these areas are just weaker in nature, and so the polyps form and it causes a lot of pain for our patients. It's really interesting when you look at the different cultures because in Asian countries, they're actually more likely to have right colon or in the cecum diverticulitis, where the fermentation and absorption takes place. So these sides have completely different functions, and the right side is associated with high microbial activity, a large fecal volume, and parasympathetic control. So the colon just works on its own to push the particles through the colon. However, in Western countries, it's more common for diverticular conditions to affect the left colon or the sigmoid colon, and this controls excretion. It's more voluntary, and there's less microbial activity and decreased fecal volume. So it is interesting when you do talk about fiber intake or diet and microbial or probiotic intake and how different they are between the Asian and Western cultures or countries, because Asian countries are more likely to have fermentation in their diet and different kinds of grains, whereas Western countries are more likely to have lower fermentation and lower fiber intake. And it's just interesting to see the differences, and you almost wonder if different microbes are involved, or genetics, or lifestyle or environmental factors. That's something that further research is needed. So when we're talking about fiber, fiber acts as a prebiotic or a substance that feeds the probiotics or the healthy, good microbes in the gut, and this can protect against inflammation and all kinds of diseases and infections. So the thought is that decreased fiber intake is associated with increased intraluminal pressure, and since Western cultures are more likely to have less fiber intake, it's of great concern because we also have a really high incidence of diverticulitis, especially in the sigmoid colon where there's less microbial activity. And when they looked at different cultures other than Asian countries, they compared Western cultures and African cultures. Well, when looking at the Western, specifically American cultures, they had lower intakes of fiber and increased meat intake and a rising aging population. They also had higher incidences of diverticular disease. However, it's been debated because the African cultures don't live long enough sometimes to determine whether it would actually occur, and they're also more likely to have just less calories in general. However, they are more likely to have more fiber intake. But they are also more micronutrient deficient. So while it's interesting to compare these, and we do have a higher incidence of diverticular disease and lower fiber intake, sometimes it's just comparing two different diseases or two different cultures that wouldn't necessarily mean that it's a causative effect. It's just an association. So signs and symptoms of diverticular disease or diverticulitis, it's associated with left lower quadrant pain. So that area where the sigmoid colon is usually where these people in America or Western countries feel that pain. And if it's diffuse, really spread out pain, it indicates a more complicated disease because infection could spread. There could be some nausea or vomiting or constipation, but usually diarrhea is very common. Some even have blood in their stools due to ruptured diverticular polyps. Some also experience dysuria because the inflammation is spread to the bladder and it's causing a decreased output of urine. And many have a fever because of the inflammation and the infection. Complications that can happen: bleeding, abscess, free perforation, a fistula, stricture formation, and reoccurring diverticulitis. So all kinds of things that put you at greater risk for morbidity, a greater length of stay in the hospital, and malnutrition, and just more complications, and you're more at risk for needing surgery or needing surgical intervention to remove these polyps to prevent further complications. And actually, urgent surgery is indicated for those cases in which inflammation and infection spreads. So these complications can cause inflammation and infection to spread, and we don't want that. The Hinchley classification was made to determine how severe the diverticulitis case is. So stage 1, there's inflammation in the colon and there might be a pericolic abscess. In stage 2, there's inflammation and a retroperitoneal or pelvic abscess. So that means that the abscess is a result of the inflammation spreading some. And stage 3 means that it's spreading even more. And stage 4, even further spreading of the inflammation. While the Hinchley classification has been used more often and traditionally, it is also an older model of determining the severity of diverticulitis, and it does not take into consideration the use of CT scans for diagnosis. So new classifications have been suggested for use. CT scans are more widely accepted and they're more used nowadays to determine the level of complications associated with acute diverticulitis. And Ambrosetti conducted a research study on this association, and he suggested subdividing groups into moderate or severe diverticulitis based on the images shown on the CT scan. So it's a little more simple than the previous complication, but it just looks at moderate diverticulitis, and it shows that there's sigmoid wall thickening only in the colon, so it hasn't spread yet, and it's thickened to greater than 5 millimeters. And there's also some inflammation of the pericolic fat. However, in severe diverticulitis, it's the same as the mild, but there's also abscess, extraluminal air, or extraluminal contrast. So it started spreading, and there's more complications associated with the severe diverticulitis. Medical management used for diverticulitis, it's starting to be debated, and there's increasing interest in moving towards outpatient treatment and less surgical intervention. This is more so with the less complicated diverticulitis cases, mostly because if it is more serious, it does need surgical intervention right away. and 15 to 20% do need surgical intervention during an initial admission. On uncomplicated cases can improve with bowel rest and IV antibiotics, so that's why they're thinking to reduce costs and hospital admission to move towards an outpatient treatment. However, in complicated cases, there's a very high mortality rate. This is when there's more spreading of the infection and more abscess and different complications that can occur. So these cases need more immediate attention, especially with the first diverticulitis incident, and surgical intervention can be indicated. And in a multi-center observational study of the left-sided acute diverticulitis performed by Binda et al., rates of reoccurrence were higher in those treated medically versus those treated with surgery. So that's why they're thinking to move towards outpatient treatment instead of medically in the hospital, because there's a really high risk of people having to come back, and so if they can prevent it outpatient-wise and hopefully diet-wise, we can prevent those reoccurring hospitalizations. And those treated with surgery didn't have reoccurrences, mostly because they're resected or that part of the colon is removed, so there's less of a chance for it to reoccur. The types of surgical interventions have also been debated. There's the Hartmann's procedure, which actually started in the 1980s, and it was used for colon cancer. And this involves a colectomy of the sigmoid colon with an encolostomy, and there is an indication for later reversal. However, up to 55% remain non-reversed, and that's even higher in our aging population. It's very standard and more well known. However, it's got a high morbidity and mortality rate. And they go off the Hinchley's level of complications to determine whether the patient is indicated for this procedure or not. More and more surgeons are trying to move more to the primary anastomosis, and this is a colectomy, but there's no colostomy at the end. They're really just trying to preserve the intestinal continuity and keep it as normal and close to the natural form as possible. It's just a resection or a colectomy of the sigmoid colon. Most of these are elective surgeries. Most surgeons don't do this unless the patient elects to. And there's similar short-term outcomes as with the Hartmann's procedure, but it is a little newer, so not as many surgeons are as willing or as knowledgeable about this intervention. So medical nutrition therapy. Fiber plays a really strong role in prevention of diverticulitis, and it was traditionally suggested that a low residue diet after incidences of diverticulitis would be better to prevent perforation and further complications, especially with consumptions of nuts, popcorn, seeds, or corn. It was thought that these could get lodged in the polyps and create further inflammation. However, there's really not any great evidence to suggest that we should be telling our patients to go on a low residue diet. It's actually been shown that high fiber diets prevent and improve symptoms and help with the management of diverticulitis and prevention of further reoccurrences. The A&D suggests to gradually increase fiber intake over time, because if you're not used to it right away, it can be very hard on your bowels. So a gradual increase in intake is suggested. So our patient, he is a 41-year-old Hispanic male. He was Spanish speaking. However, most of his family at bedside spoke English, and his wife was his primary caregiver, and she spoke for him the most. He had a really good family support. He had, I think they were maybe cousins or brothers at the bedside that were very patient and just, checking up on him and being very supportive. He has career technical training. He was a welder in Baytown. He's a completely, fully independent man, especially being a Hispanic man, probably very prideful, and he was able to do all functions prior to this event independently. When I asked him about what he eats, of course, it was very traditional Hispanic. He ate meat with every single meal, a lot of fresh flour tortillas, refried beans, and although those do have fiber, they have a lot of added fat, usually if you make it the traditional way. Spanish rice, and I'm just assuming that it's white rice because that is the traditional way. He likes his sweetbread and coffee every day, and he really likes spicy food, so he added spice to almost everything. And his family at the bedside jokes a lot that he liked his beer every now and then. I don't think he was necessarily a heavy drinker, but he did seem to drink socially. His medical history was really not very significant. He was generally in good health prior to this event. He never used tobacco or street drugs or inhalants. He did drink alcohol occasionally. He didn't really have a significant medical history. However, his father did have lung cancer, and this was his first incident, newly diagnosed diverticulitis. He had a normal bowel pattern prior to this, reporting that it was daily. Upon his physical assessment, he was in normal health. He weighed 146 pounds upon admit. He was 5 foot and 7 inches, and his BMI is 22.9. His chief complaints: he had lower quadrant abdominal pain for 3 days prior to admission. He had fever and chills, and he had diarrhea, but no blood in his stools. And his bowel sounds were hyperactive. So if this tells you anything about independence and more than likely not wanting to go to the hospital even though he was in extreme pain, it took him 3 days prior to admission. And from the notes, he was at work and not really wanting to go in. He was probably wanting to finish his work. So this can be typical with males, and it probably made it really worse by waiting so long. However, he was in such good health, he probably didn't think anything of it. His vital signs, the most notable of all of them are his blood pressure. He had a really low blood pressure. He did have a fever. I never got the exact number. However, it was written in the medical notes from the doctor. He had a normal heart rate, a normal respiratory rate. His eyes and reactions were all normal. And his range of motion and his muscle and movement was all normal in his extremities. He had no neurological deficits. However, in his abdomen, it was very soft and tender in the lower left quadrant. He didn't have any rigidity. However, there was rebound present, so that probably means that the doctor noted that there was some kind of an obstruction or a polyp or some kind of a little mass or a polyp that he could hear from his exam. The CT of the abdomen and pelvis it showed that he had an enlarged spleen, enlarged lymph nodes, numerous diverticula in the left hemicolon, so in his sigmoid colon. He had presence of free air, which makes everything worse and it increases your risk of complications. There was a large amount of thickening around the sigmoid colon, and there was paracolic fatty infiltration, which just means that all the inflammation was spreading. It spread to his spleen, to his lymph nodes, and there was infiltration and a great amount of thickening, meaning that the stool couldn't pass through normally, and it was causing a lot of pressure and resulted in diverticula in the sigmoid colon. The medical diagnosis was acute diverticulitis with perforated diverticulum, pneumoperitoneum, mild splenomegaly, reactive mesenteric lymph nodes, sepsis, and deep venous thrombosis prophylaxis. So the inflammation spread to his spleen, and it caused sepsis and more spread of infection, and he started to get blood clots. Significant lab values. So this was a very healthy patient prior to admit, and upon admission he had some slightly elevated glucose levels, indicating that there must have been a trauma. It was a severe trauma, and the low albumin levels, although it has been associated with malnutrition, it's also more so associated with acute dehydration in this instance. The others were also significant. I just really wanted to highlight these because they're more pertinent for malnutrition and dehydration in the acute setting for clinical dietitians. So prior to discharge, he had a major surgery, so his glucose levels were still slightly elevated. This is a severe trauma, and there was no indication of previous diabetes. However, this can be seen in a lot of our patients in the hospital when there's trauma or an acute stress. The albumin levels were still kind of low, and they improved, but they were still lower than the normal limits. So this could indicate that the patient was still slightly dehydrated. He had lost a lot of fluids with some recurring diarrhea, so that can be expected. The interesting part was the creatinine and potassium, because upon admit, these levels were normal. Creatinine can indicate a little bit of malnutrition and muscle wasting, and because we are concerned with that in the hospital and we don't want that to cause further malnutrition or muscle wasting upon discharge, it's important for us to note that as dietitians and make sure that we suggest a good amount of protein or add a supplement for these patients, especially because he's a very healthy patient prior to discharge, and we want to prevent further malnutrition or muscle wasting and keep him a healthy patient. His potassium was also slightly low, so this could indicate some dehydration from all of his bowel issues. So the surgical intervention outcome, this patient underwent a Hartmann's procedure, which was the common procedure that is usually done in hospitals, as we talked about in previous slides. So he had a resection of the colon with an encolostomy. The benefits of this for a surgeon is there's low risk of leakage because the stoma comes out of the body, and so there's less risk of it leaking or of the stools leaking inside the body, which is good. It can be performed by less trained or novice surgeons. It's not as difficult of a surgery compared to other colonic surgeries. However, the disadvantages are there's a second surgery needed to remove the colostomy, and this colostomy can greatly reduce somebody's quality of life and mobility and just change a lot of normal functions that they would do every day. 74% may be left with a permanent stoma, especially with increasing age. So our patient has a greater chance of not having that problem. However, in an older patient, it would greatly increase their risk for keeping that, because to undergo another surgery for those patients, it would be too traumatic for them. New studies, including the one by Toro et al. In 2014, have shown that a laparoscopic reversal can be safe and decreases complications, decreases morbidity and mortality, and greatly improves somebody's quality of life by reversing this stoma and regaining the colonic function in our patients. Medications during admit include hydrocodone, hydromorphone, and Dilaudid for pain relief, protonics for acid and stomach acid to prevent any backup of that acid that causes heartburn, Zofran to prevent nausea, and Zosyn as an antibiotic to prevent any further bacterial infections. And then he was also given a normal saline IV solution of 1,000 milliliters at 125 milliliters per hour for fluids. So the nutrition assessment, the diet history suggests inadequate calorie and protein intake to meet nutritional needs, secondary to constipation and diarrhea. The patient had ongoing constipation and then diarrhea all of a sudden, as reported upon admit. He was on a clear liquid diet post an emergent colectomy and colostomy surgery, and that puts him at a high nutritional risk because nobody can live off of clear liquids forever. And I just remember him telling me, I'm so hungry, but the doctor was really concerned with him healing right and making sure that his GI function would be regained. So he was on clear liquids when I first saw him. His energy needs were 1650 to 1980 kcal, and that's based off of 25 to 30 kcal per kilogram, and 79 to 92 grams of protein based off of 1.2 to 1.4 grams per kilogram. The nutrition diagnosis, PES statement, is altered GI function related to ruptured diverticulitis as evidenced by colostomy, status post colon resection. For the nutrition intervention and goals, I recommended to add a clear liquid boost breeze 3 times a day while he was on a clear liquid diet. This gives 250 kcal and 9 grams of protein per box, which isn't very much. However, this person and every person in the hospital is really at great risk of malnutrition and decreased muscle function, and we want to preserve that as much as possible. So any and all protein that we can give is best. Once advanced to a full liquid diet, if the PO intake is less than 50%, I recommended supplementing with Boost Plus BID. This is more of a milky-based substance that would hopefully provide more leucine and more protein for muscle function. It provides 14 grams per box, so that would greatly increase the prevention of muscle loss and increase protein intake. I recommended advancing to a full liquid diet with the goal of soft, easy to digest diet that's tolerated, to provide greater than 75% of his needs, preserve lean body mass, and promote bowel regularity. Upon monitoring and evaluating this patient, we always look at weight change, especially if they came in with an altered nutrient status upon admit or there was a nutritional concern. We always want to make sure that they are not losing a large amount of weight during hospitalization. This patient, however, had a 5.5-pound weight gain, and typically we would attribute that to fluid gain. However, this patient showed some lab values that indicate some slight dehydration, so that's mostly not likely. This patient also started in the ICU and went to another floor from the ICU after his surgery, so there could just be some discrepancy in the bed scale. However, it's always important to monitor and note any weight change in case it is significant or there is a decline in nutritional status for the patient. And the results? The patient ate really well, actually. The first assessment, he had 50 to 75% PO intake. Now, this was clear liquids only. However, on the second assessment, he was eating at least 75%, and he reported that smaller, frequent meals were easier to tolerate. He wasn't able to tolerate a whole lot at once, but he did say that he was able to eat some in between and drink his boost in between meals. The patient was discharged on day 6, which is good because at day 7, your risk for malnutrition and muscle wasting greatly increases. He was discharged with a colostomy bag, and as we talked about before, it greatly decreases an individual's quality of life. So this is concerning for a patient who is generally healthy. Other than this, it may be a really big change for him upon discharge, especially going back to work and trying to do his normal daily functions. And it's really concerning because 40 to 60% do not have it reversed. So hopefully this patient is in good health enough that he will be able to have it reversed. However, I could see that his wife was really concerned, and I wanted to give her some nutrition advice to help her in making this transition a little bit easier. For nutrition education, the wife was really concerned about the different types of foods that the patient could eat once he went home and how to prevent this from happening again. And with the colostomy, it was really a special indication for nutrition education. Not many people are very aware or familiar with colostomy nutrition therapy, so I thought it was really important to educate them and bring them some handouts that they could take home with them to know which types of foods might be better tolerated. So from the nutrition care manual provided by the Academy of Nutrition and Dietetics, I brought them colostomy nutrition therapy, high fiber nutrition therapy, and a 5-day sample menu for gradually increasing fiber handouts. Colostomy nutrition recommendations usually include eating small meals regularly, chewing food thoroughly, and drinking plenty of fluid. This is just to assess tolerance, and the patient did report that smaller meals were more easily tolerated for him, especially post-surgery. We also want to make sure the patient is aware that certain foods might cause more gas or odor than others. So broccoli and cauliflower and things like beans or lentils might cause more flatulence than others, especially with a patient who has a colostomy. It is important for the patient to still eat fiber as much as he can tolerate it, though. just for promoting bowel regularity and colonic motility and preventing any future complications associated with diverticulitis or colon issues. The biggest changes that this patient will experience are eating less spicy food, drinking less coffee, and limiting intake of alcoholic beverages. The coffee and alcoholic beverages can greatly change fluid and hydration status, so it's just important for the patient to be aware of these things. The spicy food might irritate the lining of the intestines, and so it's just important for him to limit and monitor the intake of these foods. In conclusion, diverticular disease and acute diverticulitis is common in the U.S. It's very important for the dietitian to be aware of the etiology and the pathophysiology of this disease, especially to note that patients that have higher BMI or low fiber intake or just our elderly patients are at high risk for developing this disease. And if they do have an incidence of diverticulitis, they're likely to have reoccurring incidences. And so it's very important for us as dietitians to learn how to educate these patients to prevent these reoccurring incidences. In severe cases, surgery is likely, and it can implicate serious changes to the nutritional status, not only in hydration and malnutrition, but also just in general quality of life. It can greatly change the way a patient may live, and that includes the way the patient eats after they discharge from the hospital. Nutrition not only prevents, but it also manages and promotes healing of the disease. So it's very important for us to know that we play a huge role in these patients' care. And it's really important for us to learn how to manage the disease on the nutritional side so we can educate our patients on prevention and management of the disease, especially with our special cases that have surgery or different operations as a result of this disease, and we also want to help them prevent reoccurring incidences in the future. And these are my references.